Many people around the world are currently researching nystagmus. This research spans many aspects of the condition, from fundamental mechanisms to diagnosis to visual function or to treatment methods. Included here are 9 researchers who have recently published an academic, peer-reviewed journal article on some aspect of nystagmus. Note that the term here, recent, means published within the last 2 years. Each researcher will briefly introduce themselves, then provide a short summary of their recent work on nystagmus. My name is Joe Ambrico, and I'm currently the Research Liaison and President of the American Nystagmus Network. Join me as we go globe hopping and visit these researchers and listen as they describe their recently published findings. Let's begin in the central U.S. in Cleveland, Ohio.
Thank you for inviting me to introduce myself to the group and talk about my research interest. I'm Fatema Ghasia. I am a clinician scientist with expertise in pediatric ophthalmology and binocular vision disorders and research interest in system neuroscience with emphasis in eye movement control. I am associate professor and staff ophthalmologist at Cole Eye Institute Cleveland Clinic. I did my ophthalmology residency at Washington University in St. Louis, followed my clinical pediatric ophthalmology and adult strabismus fellowship at Duke. Prior to my clinical training, I did 2 postdoctoral research fellowships at WashU under tutelage of Dora Angelaki, who's a biomedical engineer and former chairman of neuroscience at Baylor College of Medicine, and with Larry Tyson, who is the division chief of pediatric ophthalmology at WashU. During my fellowships, I had the opportunity to learn electrophysiology and behavioral experimentation of eye movement control. I direct the Ocular Motility and Vision Neurosciences lab at Cole Eye Institute. A primary focus of my lab is to understand the role of abnormal neural circuits in patients with strabismus, that is eye misalignment, nystagmus, which are eye oscillations, and amblyopia, also called lazy eye, where vision in one eye is weaker than the other. The overall goal of our research program is to use eye movement as an objective tool to identify biomarkers that can be used for diagnosis, as well as to predict visual function deficits and treatment response. Our lab has published several papers on eye oscillations in strabismus in neurologic diseases like ataxias, strokes, with more recent emphasis on Parkinson's disease. Here's our experimental setup. We use a high-resolution video eye tracker, customized LED targets to measure eye movements, and Opal sensors that allow us to quantify head movements as well as limb movements like tremor. We've also built a cutting-edge infrastructure for tracking eye and head movements simultaneously with high degree of accuracy and precision in children. We have designed pediatric-friendly visual stimuli that includes cartoons and movie clips to make the test fun and entertaining. We also have 3D LCD displays and other equipment that allow us to measure eye movements while children view pairs of videos prepared for newer amblyopia treatments. Our lab is one of the few centers globally where we have the ability to non-invasively measure 3-dimensional eye movements. Here are some pictures demonstrating children of various ages participating in eye tracking experiments. The older children, they are seated in the exam chair, whereas the younger participants, they are seated in their caregiver's lap while the camera records their eye movements. Today I'm going to talk about fixation eye movements or fixation instability, which is frequently seen in patients with childhood eye diseases. Visual system has a built-in paradox. We must fixate our gaze to inspect minute details of the world, yet if we fixate perfectly, the entire world would fade from view because of adaptation. Let's take an example. If you were to fixate on this black cross, the purple circles, they begin to fade away and disappear. Movement of your eyes bring the purple circles back into perception. Thus, during fixation, when the highest visual acuity is achieved, our eyes are not completely motionless, but instead they show miniature involuntary eye movements called FEMs. FEMs, they are known to thwart neural adaptation and counteract visual fading. Here's an example of fixation eye movements obtained in a control subject. The green and the pink represent the right and the left eye. Notice that during fixation, the eyes are not perfectly still. So when we plot their eye positions over time, we see these small miniature eye movements that occur during fixation. Another way to evaluate fixation instability is to quantify horizontal and vertical eye positions, plotting it together, and look at this cloud. If the fixation is stable, the cloud is going to be tighter and smaller, and that is quantified using a measure called BCEA. Now we know that patients with amblyopia have fixation instability. The purpose of our study was to characterize fixation instability in amblyopia, examine the effects of FEM abnormalities on visual function deficits, and examine the link between FEM abnormalities and treatment outcomes. We divided amblyopia patients into 3 groups. Those that did not have any nystagmus. So here is a video from one such patient. The pink is their amblyopic or the weaker eye, and notice that there is a drift in that weaker eye, and the fellow eye, which is the green, this fixation was pretty stable. We can see that on the eye position traces, there is that increase in the drift of the amblyopic eye, and when we look at the BCEA and we plot the fixation instability, the values are much higher, particularly when the amblyopic eye is viewing. Now we know that patients who have experienced disruption of binocularity in early infancy, they develop latent nystagmus, which is now called fusion maldevelopment nystagmus. Here's an example of a video obtained from one such patient. This is when they were viewing with both eyes and the nystagmus is evident. So this patient has manifest latent nystagmus. And then when we look at the eye position traces, there are characteristic features that predict that this patient has FMN. And the most important one is that there is a reversal in the direction of the nystagmus depending on whether the fellow eye is viewing or whether the amblyopic eye is viewing. And the quick phases are always directed towards the ear. Again, the fixation is pretty unstable as measured by the BCEA. Now, we also find that amblyopic patients can have nystagmus without FMN. So here's an example of one such patient. The nystagmus is evident, and it's most evident when they're looking with the amblyopic eye here. Again, they have instability of the fixation as indicated by this greater scatter and higher BCEA values. So what we find is that there are 3 types of amblyopia. One is an isometropia, which is that occurs because of difference in refractive error between the 2 eyes. Second is strabismus, and third one is mixed, where they have both an isometropia and strabismus. We find that patients with anisometropia, they are less likely to have FMN. Patients with strabismic, they are more likely to have nystagmus, whereas patients with mixed amblyopia, they have equal distribution of between no nystagmus, nystagmus without FMN, and FMN. Now the work from our lab has shown that FEM abnormalities are linked to visual function deficits. What we find is that the timing of amblyopia development play a role in visual function deficits in amblyopic patients. Presence of FMN is associated with greater impairment in binocular and some monocular visual function deficits of the fellow eye. So I'm going to talk about contrast sensitivity, which is the ability to detect luminance. We measured contrast sensitivity at low spatial frequency. This is easier to do because the bars are thicker, and high spatial frequency where the bars are closer together. We measured the contrast sensitivity of the good eye, which is the fellow eye, across patients without nystagmus, nystagmus, no FMN, and FMN, and compared them to controls. What we see is that fellow eye of patients with amblyopia, irrespective of presence or absence of nystagmus, they have difficulty doing the task at the high spatial frequency, whereas patients with FMN, besides high spatial frequency, also have difficulty at low spatial frequency. Next, we wanted to see how FEM abnormalities are linked to treatment response. First is we'll talk about amblyopia treatment response. So as we saw previously, FMN gets worse when one eye is viewing, and that is how we treat amblyopia, is we patch the good eye. So what we wanted to know is, does the presence of FMN affect treatment response? We found that the presence of FMN is associated with poor response to patching treatment in terms of requiring longer durations of treatment, as indicated here, where patients with FMN took much longer compared to those without nystagmus. And also the extent of visual acuity improvement was less in patients with nystagmus compared to those that did not have nystagmus. The other important finding that our study showed is that patients with FMN have poor recovery of stereopsis, which is depth perception, at the end of patching treatment compared to the other 2 groups. We found something similar when we evaluated the response to strabismus surgery. Strabismus is eye misalignment, and eye muscle surgery is used to fix it. What we find is that although the angle of strabismus improves after surgery, as indicated by by the chart here, the black is patients with FMN and the gray is patients who don't have nystagmus. And both groups of patients, there is improvement in the angle of strabismus. However, the recovery of stereopsis is poor in patients with FMN. This is pre-op, this is post-op. Majority of the patients, they don't have any improvement in stereopsis. So our take-home messages are quantification of eye movements can play an important role in management of neurologic diseases such as developmental diseases like Chiari malformation, movement disorders, stroke. Quantification of eye movements can help predict binocular and monocular visual function deficits in childhood eye diseases. Patients with amblyopia and nystagmus have improved visual acuity with treatment. Patients with FMN, they require longer duration of part-time patching treatment. And stereopsis recovery is poor with current amblyopia and strabismus surgeries in patients with nystagmus. Our future work will focus on evaluating newer treatment options such as the binocular dichoptic treatments for recovery of vision, particularly binocular vision in patients with nystagmus and amblyopia or strabismus. I would like to thank our funding agencies, Research to Prevent Blindness, Fight for Sight Blind Children's Center, and the lab members who have contributed to these projects. Thank you all.
Next, we'll remain within the U.S. and hop to the Pacific Northwest and visit Seattle, Washington.
Welcome to Seattle Children's Hospital Department of Ophthalmology. We are located in the northwest corner of the United States. Children's Hospital is a tertiary care clinic. We see children with nystagmus due to a wide variety of disorders such as albinism, rod monochromatism, retinal degenerations, and other neurological or unknown causes. Our collaborators include Christina Tarsi-Hornock, James Phillips, PhD. Jim has been instrumental in setting up the vestibular and oculomotor lab at Children's Hospital. Next is Dr. Avery Weiss. Avery has been instrumental in setting up our Children's Hospital Ophthalmology Clinic to include oculomotor testing. Next is me. I'm John Kelley. I'm a PhD. I'm also involved in measuring sensory motor function in children who are nonverbal or in young children. And we have been very active in writing up several papers about nystagmus and their possible etiologies. Next, let's show you some of the vestibular and oculomotor lab. On the left is a large platform posturography device, which allows us to measure balance in children. Next is a small dynamic visual acuity display. This allows us to measure visual acuity during eye movements, rotated or in null position, as you may know. A null position is when the head turns and the nystagmus amplitude drops. The next, there's a bench there, which is used for calorics and VEMP. And then behind that is a room. And inside that room is a large display with a rotational chair to measure vestibular ocular reflex, or watch large field optokinetic nystagmus, targeted saccades, smooth pursuit, and ocular motor measurements. The device is in a dark red room to maintain dark adaptation in case we use electrooculography. The child can be seated comfortably on their mother or father's lap. The child views the display with a binocular video oculography under normal circumstances. This usually is a two-person operation, one person to make sure the goggles are on the child's head, while the other person is recording the eye movements and setting up the stimulus for the task. Next, this is the visual sensory lab. At the left, we have a multifocal ERG. This allows us to measure retinal function at localized areas within the eye. To the right is a handheld optical coherence tomography. This device allows high-resolution imaging of the retina that is important for ruling out retinal eye diseases in small children, especially during early phases of retinal degeneration, and also helps us to assess the fovea in children with albinism or other forms of foveal hypoplasia, which can lead to nystagmus. And then on the right is a full field ERG, that's electroretinogram, and that is important for measuring other retinal disorders such as congenital stationary night blindness, rod monochromatism, both of which can cause nystagmus. And then we have a visually evoked potential device. This machine measures the brain response from the visual part of the brain to patterns presented on the TV screen. This device lets us integrate entire visual pathway all the way from the retina of the eye, the optic nerve, and the visual part of the brain. We can also simultaneously record eye movements using electroaugulography. This device allows us very high temporal precision, measuring within several milliseconds, thousandths of a second, of what the brain response is doing during the presence of eye movements in nystagmus. Behind the VEP system is our workstation. This workstation allows us to integrate all the information from the eye movement recordings, the vestibular or balance measurements, with the electroretinogram, that is the retinal responses, with the brainwave. All of that can be done using this custom software we've been developing. The advantage of this is all of this can be done right in the clinic. One reason for creating this custom software is the challenges that children present. It's not always so easy to get a clean eye movement recording or any other diagnostic test in these children. So the software allows us to carefully review all of the information and only extract relevant pieces of information. This is actually very critical in the data analysis. Now let's talk about some of the research we do. This is a plot showing visual acuity development with age. Along the horizontal axis is increasing age up to about 5 years of age. On the vertical axis is visual acuity. The higher you plot, the better your visual acuity is. The shaded area is the normal development in children. These are children who have no visual problems, they have no nystagmus. The dots plot the development of children with an unknown cause of their nystagmus. They're otherwise normal, their retinas look normal, everything about them is fine except for they have nystagmus. Notice that the dotted line is the normal development. It follows roughly a straight linear projection on this plot. The solid line is fit to all those dots. It shows that overall kids with nystagmus have reduced vision in comparison to control children from an early age. This is a little surprising because we know that some people with nystagmus will have markedly reduced visual acuity. That is, their vision is not as clear as 20/20. And so it was a little surprising to us that even if you have nystagmus, you are further impaired from normal, even though not your final visual acuity, and there's really no theoretical reason why your vision should be worse when everyone else is poor. We know a lot of this growth curve in normal children is actually due to brain development, not retinal development. In this next plot, we show you different types of plots. For each is the control, the gray shaded area, just reproduced in each plot. The dots show different kids with various forms of nystagmus, all the way to the bottom right in children with rod monochromatism. We know from research that much of the visual development is actually due to the brain, the visual part of the brain. The retina is relatively mature at a very young age, so the difference between the retinal development and the visual development seems to be largely due to the visual part of the brain. This is a theory, we have yet to prove this. Here are results from another lab, plotted with our own lab, showing that there was good agreement. This gave us confidence that our results were very robust and repeatable across labs. Next, we looked at the type of nystagmus and whether that had a differential effect on visual acuity development. And it turns out that whether you had a pendular type nystagmus or an asymmetric pendular or a jerk type nystagmus, it was hard to discriminate between the different types of nystagmus and visual acuity development. Therefore, this leads us to think that there might be more than just the waveform of the eye movement itself, but there's something about how the eye moves and the brain development. This is a set of eye movement traces. So over time on the horizontal is the eye position on the vertical. What you can see are oscillations. That is the nystagmus. So as the eye moves, we're just plotting the change in the eye position over time. We're highlighting here are little periods of time when the eye is slowest and presumably has the best way of sampling the visual world, or simply my eye is moving slow enough I can actually make out the world a little bit more clear. These are called foveation periods. We were interested in forming a theoretical framework of which we can predict whether the eye movement actually caused errors or deficits in this visual acuity development. Plotted on the top are 3 different models. These are mathematical models that try to predict visual acuity development with age. On the top plot, on the horizontal, is how quickly the eye is moving. To the right, the eye is moving really fast. On the vertical axis is their visual acuity, the estimated visual acuity based on that eye movement. Obviously, as the eye moves too fast, your vision gets worse. That's why they have an increasing line towards the right. The shaded area is the range in which your eye movements would not affect your visual acuity. The shaded area shows that if your eye velocity, or the speed at which your eye is moving, is below a certain range, then it shouldn't affect your visual acuity. The upper range is in the gray line there. That shows if your velocity is in between the black and the gray line, your visual acuity might actually be reduced based on your eye movement. What we found is that all subjects in our study had short periods in which eye velocity was below that limit that would reduce their age-appropriate visual acuity. We decided to look at the actual visual response from the brain itself. What we're showing you here is a bunch of trials where the child is looking at a repeating pattern. Normally, you'd have a very sharp blip in this recording. As you can see, everything's been overlaid on top of each other. There's a lot of noise in this recording. In other words, the visual part of the brain is generating a lot of variability during the nystagmus. Next, we're going to show you the actual eye movement recorded simultaneously from the brain while the brain response is being recorded. Here is the eye position over time. As you can see, there's a huge amount of variation in the eye position. It would all be a flat line if the eye was completely still. But inside that is a band of very quiet eye movement recording. This is also known as the null point. This is when a person can put their heads in a turned position in order to dampen the amount of nystagmus. Using our custom software, we can actually extract out those time periods when the eye was actually very quiet. Now when we look at the visual response from the brain, we get a much clearer, more significantly isolated brainwave response. In other words, it is a cleaner response from the brain. Next, I'm going to show you a much more complicated graph. On the left is the response from the brain, the visual part of the brain. And then the middle column is how much the eye is moving at the same time. We use different criteria to try to extract when is the best brainwave response possible. As you can see, at the top, when the eye is moving a lot, the brainwave response is smaller. If we can look at certain phases of the eye movement, we can see that the response is actually even smaller during certain periods of eye movement. And then the lower 2 traces show different criteria for determining when the eye is stable. And you can actually find a period when brainwave response is optimal. This research was very exciting, made us think that there might be ways of being able to find out what part of the eye movement is the vision response best, or when can it be optimized. Further research is obviously going to be needed to work on this. Next, what I'm going to show you is the amount of time that the eye could actually stay stable relative to the signal to noise. That is, signal to noise is how clean is that signal? Is it staticky? Is it noisy? Is it clean or not? So we found that there was a relationship, the amount of time that you could fix your eye at a certain location and get it to stop versus the signal to noise ratio of the brainwave response. This made us think that if you could keep your eye more stable at a certain position, you would have a cleaner response, and maybe you'd see clearer that way. This research is really in its infancy, and we need much more work to do in order to answer all these questions. But at least we have provided the framework and the tools necessary to address these concerns in the future. I hope you enjoyed this presentation. It was a very technical presentation in a short amount of time, but we hope that further research will help us to understand the mechanisms and the causes of nystagmus, and that we can better come up with methods to treat this disorder. Thank you for your time.
Now, we'll leave the US and head east across the Atlantic Ocean all the way to Leicester in the UK. Let's sit outside and listen to Dr. Irene Gottlob.
Hello, everyone. My name is Irene Gottlob. First of all, I would like to thank you for asking me to give this short presentation for your meeting. I was asked to give an overview of one of our latest publication, and which was Can structural grading of foveal hypoplasia predict vision in infantile nystagmus? Joe also asked me to introduce myself briefly at the beginning. And so, yes, my name is Irene Gottlob. I'm a clinical ophthalmologist. My primary training was in Vienna in Austria. And then I did about 4 years of fellowships at Wills Eye Hospital in Philadelphia. I worked then in St. Gallen, Switzerland as an attending ophthalmologist. And for the last 21 years as professor of ophthalmology in Leicester. And you may wonder why I have here the Cooper emblem also on my slides. This because I'm planning to move to Cooper University Hospitals in New Jersey in September to set up a new ophthalmology service. My main clinical interest is actually nystagmus, diagnosis and treating nystagmus, and we have established in Leicester a large center for nystagmus patients for all over the country in the United Kingdom. We have all the state-of-the-art diagnostic instruments here, and eye movement laboratories, OCT for adults and children, genetic investigative possibilities, etc. My more general interests are also neuro-ophthalmology and pediatric ophthalmology, eye movement disorders, strabismus and amblyopia. And also my main research interest is actually nystagmus, for diagnosis to use the optical coherence tomography in adults and children, genetics of nystagmus, eye movement recordings, and then the function of people with nystagmus, for example, quality of life, or how reading can be achieved, and obviously treatment of nystagmus, surgical treatment and pharmacological treatment, contact lenses, etc. One of my research interests is also optical coherence tomography in other childhood eye diseases and normal development of the eye, then amblyopia, genetics of pediatric eye diseases, eye and eye movement changes in psychiatric and neurological diseases, for example, schizophrenia, Alzheimer's disease, or Parkinson's disease. And okay, now let's go back to the research paper. Can structural grading of foveal hypoplasia predict vision in infantile nystagmus? And first of all, I would like to shortly speak why optical coherence tomography is important in nystagmus and in children. So, optical coherence tomography is also abbreviated OCT. OCT allows to scan individual retinal layers, almost like at a histological level. So you can see immediately in vivo, almost like a histological picture of the retina with all the retinal layers and changes if they're present. And in adults, actually, OCT is standard practice almost for all diseases. So probably many of you will have done an OCT already, either at the optometrist or ophthalmologist. However, until recently, children have been deprived of this technology. And OCT is even more important in children because they cannot complete subjective examinations such as visual acuity, or they cannot cooperate with more complex examinations. And OCT just takes a fraction of a second, and you can get a very good view of the retina. And recently, substantial progress has been made in pediatric OCT. This is how the standard OCT for adults look. So you see that the patient has to put his head on a chin headrest and stay still and cooperate, and obviously infants cannot do this. This is how the OCT, the handheld OCT for young children looks. So this is a probe that can be pointed at the eye of the child, and there's not much cooperation necessary because, as I said, in a fraction of a second, an OCT scan can be done. And you can see here on the screen whether you obtained a good scan. And this is actually a picture of the back of the eye. And you can see here the optic nerve and the vessels coming in and out of the optic nerve. And we are interested here in the fovea. This is the zone where the retina is very specialized for sharp vision, so the sharpest area of vision. And with the OCT, we can just take a scan through the retina, and you can see this here. You can see here the optic nerve. This indentation corresponds to the optic nerve. And then you can see here peripheral retina, and here this fovea, the fovea corresponding to this area here, which looks different and is specialized. These are the photoreceptors. They are larger here than in the periphery. And the inner retinal layers are not present in the fovea because this allows better optical resolution. And so this is how the normal fovea looks. Why is this important in nystagmus? It's because in many infantile nystagmus forms, there abnormal foveal development occurs. This is called foveal hypoplasia. For example, in albinism and aniridia, in achromatopsia, but also in retinal dystrophies, and even in idiopathic nystagmus. Here you see examples. This is a normal OCT of a normal fovea. You can see here a deep indentation in the fovea, and the inner retinal layers are not present in the center, and very large layer here of the photoreceptors. But here we see two patients with albinism. So this, the fovea hypoplasia is here developed to a different degree in these two people. Here there's still a foveal pit, but a small pit as compared to the normal here. But we see still also elongation of the photoreceptors in the center of the fovea, but also not as well developed as in the normal fovea. And in this patient, there's no foveal pit. It's a more severe degree of foveal hypoplasia. There's still a little bit of elongation of the photoreceptors, but minimal. And in aniridia, actually the changes on OCT look very similar. In achromatopsia, in contrast, we can usually see here hyporeflective zone in the area of the photoreceptors, which reflects abnormal photoreceptors here. There's also abnormal inner retinal layers, persistent inner retinal layers, which corresponds here to foveal hypoplasia. And so what we try to develop is a grading, so we have different severities of grades of foveal hypoplasia, and to see whether this corresponds, first of all, in adults or cooperative older children to visual acuity, to a certain visual acuity. And what we found is, so we have developed grade 1 to 4. 4 is almost looks not like fovea, like peripheral retina, and 1 is a very mild foveal hypoplasia with well-developed photoreceptors. And then also an atypical form, like in achromatopsia, where there are abnormal photoreceptors as well. And what we found is that each of these grades corresponds to a bracket of visual acuity. And so what we were wondering next is, can structural grading of foveal hypoplasia predict vision in very young children, can predict later vision of these young children? This is obviously a question when parents have first a very young child with nystagmus, but they're very interested what vision, what will my child develop. And this was a paper we recently published in ophthalmology. So Roberto was the first author. He's a clinical lecturer in Leicester. And so what we did is we recruited patients with an approximate mean age of 1 year before they could do visual acuities. We recruited 38 patients and did OCTs of these patients. And this was a group of mixed causes of nystagmus, albinism, idiopathic infantile nystagmus, and achromatopsia. And we followed these patients when they could do reliable visual acuity at a later age, an average age of over 4 years. And we compared the grading at recruitment at a young age with the visual acuity at the older age. And you can see here the results. So what you can see here are the different grades of foveal hypoplasia. Here no foveal hypoplasia, grade 1, 2, 3, 4, and atypically. And you can see here the visual acuity. Because this is a logarithmic scale, 0 is the best visual acuity, and this is the worst visual acuity. And what you can see without foveal hypoplasia, the median visual acuity was the best, and this decreased with increasing grade of foveal hypoplasia. Grade 4 was the worst, where we have kind of equivalent to peripheral retina, no fovea at all. And so we found this OCT at a young age a very good predictor for future vision. This was successful in 81 out of 90 eyes, but obviously you can repeat this also at another examination day if it doesn't work out. And we found also that we correctly predicted in 69% of the children the visual acuity within 3 lines. In conclusion, OCT is very useful in diagnosing nystagmus forms, and in small children, OCT has a good predictive value for later vision. I would like to thank the Leicester team because they put all their work in this research, and also would also like to thank the grant bodies who supported our research in Leicester. And I'm looking forward to collaborate with you and your association and to work for you actually. And I'm hoping for your support to establish a Center for Nystagmus in New Jersey. Thank you for your attention.
From Leicester, in the UK, we make a short hop to Eastern Europe and touch down in Copenhagen, Denmark.
Hello, my name is Lene Kessel. I'm a senior consultant in pediatric ophthalmology. That's an eye doctor for children. And I work at the Department of Ophthalmology at Rigshospitalet in Denmark. And I'm also an associate professor at the University of Copenhagen and the University of Aarhus, both in Denmark. I would like to present to you a study we did on epidemiology and causes of nystagmus in babies. And this study was described in a paper that was published last year in Acta Ophthalmologica, and it's entitled Prevalence and Causes of Infantile Nystagmus in a Large Population-Based Danish Cohort. As many of you will already know, nystagmus, these unsteady eye movements, it may be a sign of severe disease. For a normal baby, eye contact is usually established around 6 to 8 weeks of age, and by 3 months of age, the baby should be able to fixate and keep a steady gaze and to follow objects visually and with the eyes. If the child has congenital or infantile nystagmus, it usually presents around the time when a steady fixation is otherwise normally established, that is around the age of 2 to 3 months. So even though we call it congenital, which means that it's something that the child was born with, actually the nystagmus is not always seen right after birth, but usually only after a few months. And as there can be a severe disease underlying the nystagmus, it should always raise concern, and the children should be seen by an eye doctor and preferably also by a pediatric doctor. So we asked ourselves, what are the most common causes of nystagmus in children in Denmark? And we did a retrospective review of medical charts from hospitals, where we looked at the notes from both eye doctors and pediatricians, and we looked at all the information that was available in the medical charts, that is brain scans, and if any kind of electrophysiology was done of the eyes or the visual pathways, and that is measurements of how the eyes work and how the eyes communicate with the brain. And then if the children had any kind of blood test done, or including genetic analysis, we looked at that as well. So we did a population-based study, and as I said, it was based in Denmark. And Denmark is a small country in Europe, in the north of Europe. It has a population of a little less than 6 million people. And our hospital, which is placed in the capital part of Denmark, covers 1/3 of the Danish population. And our uptake area has an average of 22,000 births per year. And we identified all children who had a diagnosis of infantile nystagmus. And in total, we had 103 children in our study. And if we looked at how common nystagmus is, so the main issue here is how old the child was when it was born. If the children were born preterm, that is before the expected delivery date, nystagmus was much more common than if the child was born at term, so that is when the delivery was expected. And the more preterm an infant was born, the more prevalent was nystagmus. So in those who were born extremely preterm, that is before week 28 of gestational age, nearly 100 out of 10,000 children had nystagmus. Whereas those who were born at term, it was only 4.4 children out of 10,000 live births that had nystagmus. There was an equal number of boys and girls, so that nystagmus was not more common in boys or in girls. If we look at the causes of nystagmus, you can see here on this pie chart that 20% of the children, they had some kind of neurologic disease or syndrome underlying the nystagmus, and 44% had ocular disease as a cause of the nystagmus. In 4%, we did not find any cause, but the children was born premature. So they were premature, but they did not have any eye diseases, and there were no signs of neurological damage on the brain scans. And in nearly 1/3 of the children, no matter how closely they were evaluated and how much workup had been done, we were not able to identify a cause, and this is what we call idiopathic nystagmus. And idiopathic just basically means that we do not know the cause. If we look further into the ocular causes of nystagmus, you can see here that albinism, so that's the lack of pigment in eyes, hair, and skin, was quite a frequent cause. It was in 20% of those who had nystagmus because of eye disease. Some had nystagmus because of eye malformations. So that could be a small eye or other kind of eye malformations. Some had nystagmus because of damage to the optic nerve. That could be damage that was encountered during pregnancy or at delivery. And 13% had nystagmus because they had a disease in the retina. So usually this would be either achromatopsia, where the child is unable to see colors and detailed vision, or Leber's congenital amaurosis, so where the child is unable to see mainly in dark, but also as the child gets older, they will have increasing problems also during daylight. 11% had retinopathy of prematurity, so that's an eye disease that affects prematurely born children. And in 11%, the nystagmus was because of cataract, so a clouding of the lens in the eye. Some children were born with very small optic nerve. This is what we call optic nerve hypoplasia. And that was also a common cause of nystagmus. Some children had nystagmus related to changes in one particular gene, which is called PAX6. and this gene is very important for the development of the eye and for maturation of all parts of the eye. And in some children, 7%, the nystagmus was caused by foveal hypoplasia. And foveal hypoplasia, that's when the central part of the retina, what we call the fovea, does not develop. And this is where you have the most detailed and accurate vision, so where you can see very small letters or symbols or signs. And if this part of the retina does not develop appropriately, then we call it foveal hypoplasia. And then the children is not able to have a detailed vision, and that is what causes nystagmus in these children. So we also looked at how many of the children with nystagmus who had refractive errors, so that is a need for glasses, and we found that nearly 10% of the children had extreme hyperopia, so that's extreme farsightedness, more than +5 diopters. And it was, if we looked at less extreme hyperopia, so that's between +2 and +5 diopters, that's again farsightedness, it was present in 1/3 of the children. Myopia, nearsightedness, was present in less. Excessive myopia, more than -5 diopters, was present in 2.5%, and myopia between -2 and -5 diopters was present in 3.7%. So the group in between hyperopia and myopia, we could call them low refractive errors, and that's where the children as infants probably or most often do not need glasses. That was in 50% of the children. So 50% of the children needed glasses for high refractive errors, and 50% did not need glasses, at least not in the first years of life. If we look at strabismus, so that's a squint, or when the eyes do not point in the same direction, it was quite common. Nearly 60% of the children had some kind of squint. Esophoria and esotropia, so that's where the eyes are, or one of the eyes or both eyes are turned inwards towards the nose. That was the most common. And exophoria or exotropia, that is where the eyes are turned outward, either one eye or both eyes point outwards, away from the nose. That was less common. If we look at visual acuity, so that's the visual function, it was below normal in more than half of the children at the latest follow-up. And here down on the x-axis you can see the age at follow-up, so the children were followed from birth and then up to 9 years of age. And all those who are here in the red circle, they're the children who are below the expected visual function for their age. And for those who had idiopathic nystagmus, so nystagmus but where we did not find an underlying cause, they had the best vision, whereas those who had neurologic disease or eye disease, they had the worst vision at latest follow-up. So in summary, nystagmus is much more common in those who were born prematurely. We found neurologic disease or syndrome in 1/5 of the children. So it's really important for eye doctors and pediatricians to work together on these children and to be sure that the children get the right workup and the right follow-up. And the most important message, I think, is that although these children, when they present first, they may appear completely blind, they appear not to see their parents, not to look at objects, but with time they nearly all improve and gain some visual function. So it's really about staying optimistic with these children and encouraging them to use their vision and to accept that they will need time to learn to use the vision they have with the nystagmus. And with this, I greet you from Copenhagen. I hope you will have a nice day.
Now hang on, because we're doing a 180 and hopping on a return flight right back to the UK. This time we'll end up in the southern end, on the coast, in Southampton. There's a flourishing research center there, and we'll hear from 2 researchers. First up is Daniel Osborne, followed by Dr. Helena Lee.
Hello, My name is Daniel. I'm an orthoptist in Southampton in the UK. Southampton is famous for being the place where Titanic set sail 109 years ago. We're also growing in fame for our children's eye research, in particular the research that we're doing with children with nystagmus. I'm an orthoptist and I'm very interested in children's visual development and how that is affected by different eye diseases. So, for example, children are born as infants without the ability to see very clearly, and they have to learn to see, and actually it takes until about the age of 7 years when they have the full visual development completed. So these first 7 years of life are very important when children are learning to see. So it's important that we have measurements of how well children at this age group, age 0 to age 7, can see. Currently, we rely on a test called a visual acuity test. It's something that everybody would have done. It's a Snellen's chart, so a big letter at the top, small one at the bottom, and we ask the patient or the child, what is the smallest letter that you can see? We can adapt it for children to use pictures instead of letters, but it's largely the same test. It's what's the smallest black on white picture or letter that you can see. We use this measure to then make decisions about how we're going to treat patients, whether or not we're going to treat them, with all sorts of different options that we have for different diseases. And it's a very important measurement in all ophthalmology clinics. So how does this work for people with nystagmus? Well, people with nystagmus have a huge range of visual acuity, some with very poor visual acuity and some with actually quite excellent visual acuity. However, those with excellent visual acuity still seem to report some visual problems in their day-to-day life. A common complaint we might find is that people with nystagmus can find it difficult to recognise a face among a crowd of other faces. So an example might be that a child might take a little while to find their mother who is picking them up from nursery amongst a crowd of other mothers that are picking up their children. This was first mentioned to us by a patient, so we started asking other patients what they thought about this, and it was something quite common. It's actually that children and adults, both with nystagmus, both seem to have some problems finding a recognisable face amongst a crowd. So this got us thinking, how can we start measuring about this accurately? And we live in an age where we can quite easily do it with an iPad or another tablet. But we use the iPad app, and that's just what we choose to use, where we can present a number of faces to a child, but only one of them is recognisable. So initially we used the patient's mum, and then there was 8 or 9 other faces that weren't their mum. We asked the child to pick out their mum by tapping the screen, and we could measure exactly how long it took the child to find their mum. We could then compare this with the patient with nystagmus to somebody without nystagmus and see if actually the patients with nystagmus were indeed slower at finding their mums compared to somebody without. We did that exact study and found exactly that. It did seem that children with nystagmus were a little bit slower at finding their mothers. We couldn't fully conclude that this is certainly because of the nystagmus. However, it got us thinking, how can we use this effect and what do we need to know to use it accurately and safely? So what would its uses be? Well, it would be very helpful in the clinic, quantifying how well children can see when we're thinking about our management plans. And also it would be useful in a research capacity. So, for example, we're hopefully going to be coming up with some new treatments for nystagmus, and that over the next kind of several years and period of time. And we would like to know if those things are effective. But we know that our visual acuity has a huge range and may not be that accurate for patients with nystagmus. So perhaps this measurement that we've developed, how long it takes to find a picture of your mum using our iPad app, might be a more useful measurement when we're thinking about testing treatments in a research setting. So how are we going to know whether or not this is an accurate measurement? Well, we're going to repeat it in a few patients. So far we seem to have shown that there is a difference between nystagmus patients and patients without. So what we will now do is recruit a lot of patients with nystagmus and ask them to repeatedly do the test using the iPad app. if we find that there's lots of variability, then perhaps we can be aware of different things that might cause the app to be difficult to use. If we find this is very repeatable, we can start thinking about using it in the clinic and perhaps in a research setting to monitor progress with different new treatments that we're developing. So this is our next stage. So we've shown that we've developed the app, shown that it seems to be different for patients with nystagmus compared to those without, and now we would like to develop it into a clinical test and a useful research tool that we can use to measure the treatment's effectiveness. So thank you for listening.
Hello, my name is Helena Lee. I'm an associate professor and consultant pediatric and adult neuro-ophthalmologist working at the University of Southampton and Southampton General Hospital in the UK. I diagnose and treat children and adults with nystagmus. I've previously done a lot of work on using OCT imaging to diagnose children with nystagmus. I'm currently working on developing novel treatments for albinism, work which is funded by the Medical Research Council, and I'm hoping to get a clinical trial of L-DOPA treatment for infants and young children with albinism underway later this year. In addition, I am a member of the Nystagmus UK Eye Research Group, or NUC group, and the paper which I am going to summarise is the first output from this group. So why did we write this paper? The management of children with nystagmus in the UK is variable, and patients report hugely different experiences. For this reason, the 5 specialist centres across the UK produced a consensus on investigation and clinical management of nystagmus in children. We outline how a basic clinical assessment is done and provide a guideline as to the important questions that need to be asked as part of a thorough history and the key signs to look for on clinical examination. We also include red flag signs that would alert the clinician to the possibility that the nystagmus is due to an acquired cause as opposed to being congenital, which requires further investigations like brain scans. We emphasize how a simple, methodical assessment of a child's nystagmus can provide key information in order to direct further investigations. We then go on to show how to best use specific tests in conjunction with a detailed history and systematic clinical examination to help diagnose the cause of the nystagmus. OCT machines, for example, are special cameras that take very detailed cross-sectional pictures of the retina. They can identify structural abnormalities of the retina and can help to focus the investigation of nystagmus into those conditions likely to be associated with retinal disorder, such as albinism and achromatopsia. Eye trackers can objectively record the eye movements and help to diagnose typical infantile nystagmus or identify other eye movement abnormalities. Eye tracking can be very useful for surgical planning in nystagmus by identifying where the null zone is, which is the position where the eye wobble is minimized, or by identifying periodic alternating nystagmus, which is a type of nystagmus where the direction in which the eye wobble varies in a cyclical manner, and that requires a different type of surgery. Electrodiagnostic testing tests if the electrical function of the retina and its connections to the brain are intact, a bit like an eye version of an EEG. It can help to distinguish between the different retinal and optic nerve conditions that are associated with nystagmus. Some examples include Leber's congenital amaurosis, achromatopsia, optic nerve hyperplasia, and albinism. Genetic testing, especially panels that can test multiple genes at once, form a very important part of diagnosing nystagmus. Access to this has improved significantly since funding for this has been centralized in the NHS. We provide a flow diagram of how to streamline the diagnosis of children with nystagmus, recognizing the limitations and inconsistent access to clinical equipment across the UK, hence different options at various stages of the process. We then summarize the array of optical, medical, and surgical options that are available for nystagmus. This includes simple measures such as refractive correction using either spectacles or contact lenses. Prisms can be incorporated into spectacles to take advantage of a null point. Gabapentin and memantine treatment have been shown to be effective in reducing nystagmus intensity and improving visual function in adults. Surgically, it can be beneficial both in terms of visual function and management of neck strain to correct significant head postures. Finally, we outline the importance of ongoing management and support of children with nystagmus. This includes access to low vision support, appropriate information transfer between care providers, and access to patient support groups and information resources. Ultimately, it is hoped that this paper will help us move towards improved health equity across UK centres for children with nystagmus. Thank you for listening to this talk, and I hope you enjoy the rest of the conference.
As I mentioned, we're globe hopping. We're headed back across the Atlantic to touch down in Toronto, in Canada.
So hello, I'm Dr. Daibert-Nido. I'm going to show today my research at the University of Toronto in the University Health Network. It's about biofeedback for nystagmus. I have no financial interest in this presentation. Graduated from the University of São Paulo in Brazil, and for 21 years I've been practicing pediatrics, including strabismus surgery and nystagmus surgery. And I graduated in low vision rehabilitation at the University of Toronto 4 years ago, and have been practicing since then. So our research is about biofeedback training, a method that involves perceptual learning, and the patient learns how to control the nystagmus movements, to stop, to dampen the nystagmus, and consequently the vision improves. So the concept involved in biofeedback is the attention from the brain to the eye movements, learning how to control them, and the brain plasticity involved may memorize this mechanism in order to use them whenever necessary. This is the machine that we use in our department, and we work also with children, of course. And when we look to the screen of the machine, we can see the back of the eye and we can see the eye movements while the patient gets a feedback with a sound and also light. When the patient gets a longer beep, it means that they are controlling the eye movements and they should train how to stay there for longer and longer time. They will practice 20 minutes every week for 4 weeks. Let's exemplify a little bit. This is the feedback.
Yes, try to control your eyes.
So this beep is no good.
Okay.
They have to stop the eye shaking.
Yes,
Now,
stay there.
you see the camera? The eye is more still. And now the patient is controlling. And again, and they go many, many times. The first patient we did was an 11-year-old boy. He was healthy, but had idiopathic infantile nystagmus, which means only the motor aspect was affected to produce the nystagmus. So the visual acuity was 20/63 in the right eye, 20/80 in the left eye, but compensated with binocularity with both eyes was 20/50, which is not that bad, but it's not good because many contrast stereopsy is lost with this vision. It is about 40% of vision if we consider these aspects of the visual acuity. It was a high frequency nystagmus, and we treated with 4 sessions of 20 minutes each. After the sessions, mother related that the patient was reading at school much easier. Overall, his vision was better. And the boy told me he was seeing better the video games, his targets on the screen. Vision improved from 20/50 to 20/32 using both eyes, which means from 40% to 70%, more or less. It's a huge thing. So we gathered some cases we treated, and we published this abstract in the ARVO poster annual meeting of 2020. The age in average was 9.3. 50% of the patients were female, and there was albinism, macular scar, and idiopathic nystagmus involved in this group. They received 4 sessions of 20 minutes. The vision improved 1 line for distance and for near. Fixation stability had a strong trend to improve as well. Stereopsis improved from 228 to 74. Contrast sensitivity improved 2 lines. And reading speed improved from 51 words per minute to 86. So here is the screen. Each green dot means an attempt of fixation from the patient. So it means the eye movements. On the left picture, the eye moved inside these 2 ellipses. But on the right, it moved around this very much smaller ellipse, which means the eye is much more controlled. And the vision improved, of course, from 2050 to 2032. Here, ocular albinism child of 5 years old. Before training, the area was much bigger, and after training, much more condensated, the eye was more steady, improved from 20/126 to 20/80 of vision, which is a 2 lines improvement. Here's an adult, a young lady with a macular scar. And you can see on the left, the area is really big, and on the right, much more controlled. Vision improved 2 lines, and it was not a good vision, 20/160, improving for 20/100. A patient with 66 years old with oculocutaneous albinism. He didn't improve the distance vision, but the reading skills in 1 line, as we see in the picture, because the area condensated much more after training. So we published this prospective controlled study this year, in which we assessed post-biofeedback training, all the visual functions and quality of life outcomes in pediatric nystagmus, all of them idiopathic. So after training 4 weeks, 1 week after, the patients improved distance and near vision, as you see here in the graph. The column on the left is baseline. The middle column is a pre-measure we did, still without treatment. And the third column on the right is the post-biofeedback result, which is about 1.5 lines better. And for reading, for near reading, it was much better, as you see here. The age was in average 9 years old. We also assessed the stereopsis again, and it was significant improvement from 283 to 39 seconds. Also the reading speed, 74 words per minute to 104, and contrast sensitivity also from 0.26 to 0.08, which means all the variables we studied we improved after training with biofeedback. And here's the practical aspect, the quality of life of the children. The mothers answered to the questionnaire validated for children, and all of the categories improved: general vision, competence, personality, and family impact from the disease, from the nystagmus. So we followed so far 5 children from the 10 children in this study, and they stayed steady in their improvements. As you see here, this patient in blue improved 1 line and kept like this until 3 months, here until 4 months for the orange, until 3 months for the yellow, and until 5 months for the gray. The blue patient on the bottom never improved, so was also stable. The patients actually, they choose when they want to use the biofeedback training results. They have this ability, but they don't always use it. When they want to talk to a person, they may remember and hold the eyes steady to talk to a person or to see sharper on the board, to read. They use whenever they need it. And in terms of side effects, the only thing is the tiredness during the training sessions. They get really tired, but no other side effects. And we require an ophthalmologist trained, specialized, preferably in children. although we do a lot of adults too, all kind of nystagmus, but the studies we have are about children. And we need a trained technician because it's not very easy technically to obtain those images, to calibrate the machine and to get the training done. It's challenging, especially for children, but also because we are treating nystagmus. So if you have any interest to participate or to ask me questions, please feel free to email me on this address, okay? Thank you very much for your attention.
Let's continue our peek at biofeedback research, and once again hop back across the Atlantic and visit Florence, Italy.
Thanks, Joe, for inviting me to present our research in the field of nystagmus. I am Roberto Caputo. I am the chief of the pediatric ophthalmology unit of the Meyer Children's Hospital. The hospital is located in Florence, Italy, and we are deeply involved in all the fields of pediatric ophthalmology. Nystagmus, of course, is one of those fields, and we have done in the last few years some research on nystagmus. We presented a few months ago, and we published these results in the European Journal of Ophthalmology, the results of our research on the rehabilitation of young patients with nystagmus using a microperimeter. In our hospital, we have low vision outpatients clinics, and we have an optometrist, Helena Lee. You will meet her later on. And she used the microperimeter to make a diagnosis and rehabilitation in patients with low vision, like, for example, patients with maculopathy, Stargardt disease, and so on. In the last few years, we've tried to use the biofeedback rehabilitation with the microperimeter in patients with nystagmus, and we have published the first results that we obtained in the last few years.
Hi everyone, I'm Helena Del Magro, the orthoptist involved in the biofeedback training.
This is the microperimeter with biofeedback that we use for the diagnosis and rehabilitation. Now I will show you a patient with nystagmus during the rehabilitation. As you can see, when the patient can fix the target, the noise of the biofeedback transforms in a music, and the patient feels that is fixating better. Here you can see the chart of a 12-year-old patient with nystagmus. In the middle, you can see the jerks of nystagmus. In the upper right square, the distribution of the fixation points is plotted. This is the chart of the same patient after the training with the biofeedback. You can see in the middle there is a reduction of the jerks of nystagmus, and in the upper right corner the distribution of the fixation point is more concentrating. These results are consistent with an improvement of visual performance. These are, of course, only preliminary results, and we are trying to analyze more patients with nystagmus to test the real efficacy of this kind of rehabilitation treatment. Thank you everyone for your attention.
Our final hop is a big one. We're heading halfway around the world to visit Jinan, Shangdong province in China.
Dear my friend and colleagues, good morning, good evening. Thank you for the invitation. I am a pediatric ophthalmologist and a director of Jinan Purui Eye Hospital. My hospital is one of the 19 hospitals of Bright Eye Hospital Group in 18 provincial capital cities. This is Jinan, where I work. I used to work at National Eye Institute of NIH as a postdoc fellow and then worked with Roberto for 15 years. Now I focus on nystagmus treatment, including surgical treatment and vision rehabilitation. I strive to reduce nystagmus so people with nystagmus can get a better vision and a better life. However, most nystagmus surgery are designed for anomalous head posture, not for reducing nystagmus. It's like head turn, chin down, chin up, and head tilt. We know that full muscle recession can reduce nystagmus. However, it was used only for patients with primary head posture, and the results are not consistent and satisfying. What we can do? Is the amount of recession enough? Observation shows that eye can move after the pulling eye muscle are detached. So you can see the eye still move after the horizontal detached. That indicates that we can increase the dose of recession. So large dose of rectal recession just move the muscle insertion to the back of equator like this. However, when we do that, we got a problem. So the muscle grew back. This is a case that the new insertion is at about the equator, not far back to the equator. So with this situation happened, so the nystagmus is not satisfiedly reduced, and strabismus developed. So we may need a resection like this. So after the resection, the muscle can be reattached to the global and to the back of the equator. So recession plus resection on the same muscle is what I do. So we will have adjustable suture on each rector. So adjustment can be made if any deviation occur. Also, we can vary the amount of recession to take off strabismus and any different size of the head posture. Here's some video showing some results: pre-op, post-op, pre-op, post-op. The result is very clear. So also some more video. You can see the eye movement, nystagmus movement before surgery, and almost the eye doesn't really show any nystagmus after surgery. So it also works for head shaking. As you can see, the before surgery and after surgery. So rectal recession resection. This surgery doesn't actually limit the version. You can also see that's what we worry about, if the version can be limited. So after surgery, the works well. However, post-op deviation occur in 3% of the patient. So we will have to do another surgery to correct them. So the works for head turn, chin down, chin up, and the primary head posture, including the multiple planar head posture. If you do the horizontal recession first, you can choose that, and also works for head shaking. So there are about 400 to 500 patients with nystagmus was operated in each year in the recent years. So then after surgery, we want to improve the vision. Of course, we have regular approach like glasses, vision exercise, but we usually use the binocular therapy, not monocular occlusion, to improve the vision, because better stereopsis, better improvement, and good for patient with nystagmus. And also we have a dark exposure research program. So using binocular therapy, so we can have the vision improved very effectively for those patients that has already failed to the occlusion and atropine penalization therapy. This works, and also gain the stereopsis. So about the dark exposure research program, 81 patients and 150 amblyopia eye, and here are the results. Okay, so about 6% doesn't have any response. So 1 line improvement, so 2 line, some 3 line, 4 line, some also have 5 or 6 lines, even 7 lines. It's very effective. But for if they use the regular treatment, this doesn't really work. It doesn't improve that much. Some patients tried vision therapy or dark exposure research program before nystagmus surgery. They failed to get vision improvement. Then we learned that it is difficult to improve vision before nystagmus improved or reduced. So discussion. The main purpose of the nystagmus surgery is to reduce nystagmus, not to treat anomalous head posture only. The same muscle recession and resection may be an additional option for nystagmus surgery. So it is important to reduce nystagmus because post-op vision improvement depends on nystagmus improvement. Vision improvement in patients with nystagmus is our major goal to reach. Dark exposure research project after operation can give us further vision improvement. However, our major challenge is that many people, including many doctors, eye doctors, does not believe that nystagmus can be treated and vision in nystagmus can be improved. We will have to work hard to help more and more people to get better vision and better life. Thank you.
Thank you for joining me on this tour of recent research on nystagmus. We have certainly racked up some frequent flyer miles. I hope this tour has given you a small glimpse into the type of research on nystagmus that is currently being done around the world. And on behalf of ANN, I would like to sincerely thank all of the researchers who spent their time to contribute to this video. If you'd like to know more about nystagmus, please visit the American Nystagmus Network's website at nystagmus.org.